We'll go into our last interesting case for this section. The next case will be presented by Dr. Wiphut. Dr. Wiphut is going to share us a case about hybrid aortic arch repair. Let's welcome Dr. Wiphut.
Hello, good morning, everyone. Thank you for having me here. I would like to sharing about an interesting case of the challenging encounter to the distal aortic arch. Disclosure, this is not my case, but it's still interesting. I have to give credit to Dr. Wiphut people who came up with the idea during the hard time of the operation. And this conference is supported by Medtronic company. Here we have 66 years old lady diagnosed with chronic aortic dissection type B with many underlying disease, especially on COPD, and she had a chronic infection, so she had quite emphysematous lung on her CT scan. She presented with chronic chest pain for about a month. Here showing an axial cut of CT scan. Yep, we can see the CT scan that there's such a distal arch aneurysm there, and the size of 55 millimeter, and the disease goes through the descending aorta to just above the celiac trunk. Over there, the distal part of the descending aorta size around 38 mil. The rest of the aorta were good except her right common iliac artery. Here we show the coronal cut and the sagittal cut of the CT scan. Right. You can see it is quite tempting to do the T-bar. We can put the proximal landing zone to zone 2 and put the distal landing zone to the very distal end of the descending aorta. However, we decide that there's still a diseased aorta of the distal part of the descending aorta, so we decided to do the open operation. So we decided to replace all the descending aorta with the circular arrest for proximal anastomosis. We cannulate at the left axillary artery through the 8 mil graft, and we also put a bypass on the femoral artery and femoral vein. However, after we entered the chest wall, we found that there was a severe adhesion of the lung parenchyma to the pleural cavity, and we were unable to expose the proximal descending aorta because the lung was very bad. And we at the time we thought that if we still dive or dig into that adhesion, we might face of the severe bleeding or maybe a prolonged air leak for that lung tissue. So at that time, we decided to change only the distal part of the descending aorta. As showing here, we used the 26 mil graft for the mid to the distal part of the descending aorta, and we also do the bypass to the left axillary artery through the thoracic incision. So after the operation day 1, there is no spinal cord ischemia and no active bleeding or air leak. So we decided to do the stage TIVA in the next day. Here we can see that the proximal landing zone is quite good. So we decided to put the TIVA to the zone 2 and a little bit partial cover to the left common carotid artery. Here's the plan. We can see both of her femoral artery were good, and I decided to choose the right femoral artery to put the main device. Yep. So we used 2 stents as showing here, and with a bottom-up technique, oversized as showing here, and the results were good. The post-operative day 1, there was no sign of spinal cord ischemia after TIVA, and there was no endo leak, and patient hospital stay was totally only 10 days after the operation, and she was recovered well. So after 1 year of the operation, we repeat the CT scan as showing here. Okay, yeah, the stent placed well in that place, and the flow is good to both of the common carotid artery, and the left subclavian bypass from the distal part of the 26 mil graft still good. Here we show axial cut or CT scan here. You You can see the positive remodeling of the distal part of the arch of the descending aorta too. Right. Also the again with the coronal cut and the sectional cut of the CT hole aorta. Here we can see a really good remodeling and no endoleak. So I really wonder, are we the only one who do this? So I searched on the internet and I found that on 2022, Dr. Masahiro Diamond from Osaka University also proposed this on the publish. Yeah. So they face the same situation as us. When they about to replace the descending part of the aorta, they found that a severe adhesion from the chronic lung disease too, or maybe from another previous operation like total arch without any first elephant trunk. So they decide like us. So they decide to do the distal descending aorta replacement and decide to do TIVA again later. They propose two cases. Another case, they also replace through beyond the abdominal branches. Yeah. However, the difference is the duration before they put the TIVA. In our case, we decide to put TIVA right away after the first day of the surgery when we see that there's no clinical of paraplegia. But in this paper, they propose that they decide to do the TIVA after first operation for 2 weeks to 1 month. So with this kind of operation, the good thing is we also eliminate the risk of endoleak type 1B because we put the graft to put a stent graft to the vascular graft, so there's no leak. However, we still don't know that what is the true incidence of the spinal cord ischemia for this procedure, and we still don't know what is the optimal timing for an interval timing to put the TIVA after the first operation. And when you put the TIVA, there's still a risk of the endoleak type 2. In conclusion, the hybrid TIVA with surgical provided distal landing zone may be a good option for any challenging encounter to distal aortic arch. Thank you.
So we have our last discussion for this section. So any question from panel or any comment from panel?
Congratulations for Dr. Wiphut. But for the last mention that you mentioned about the optimal timing to prevent the spinal cord ischemia in this kind of stage procedure, the papers from Randall Grip that normally we need around 5 days to create the collateral pressure from the long segment cover. So normally, if you want to do the state procedure and to prevent the spinal cord ischemia, so normally we need around 5 days to 7 days, around 1 week to do the state procedure to make the enough collateral blood pressure for the spinal cord.
Thank you, Dr. So for giving me an update to that. Thank you. Yes, please.
Dr. Brun.
Well, thank you very much, Dr. Wiphut, for a nice case. My question is, when we put the stent graft inside the surgical graft, it's a Dacron graft, right?
Yes.
The first graft. And
yes.
we know that it can be dilated over time, maybe up to 30% in the future.
Yeah.
So my question is, how much oversize will be more secure? Because you mentioned you have 24% oversize.
Yes.
And I'm not sure that in the future, if the surgical graft were dilated, will that cause a problem? And the second thing is that how much overlap you suggest for this stent graft inside the surgical graft?
Yes. So far, we oversize around 20 to 30% of the stent graft to the Dragon graft. Yeah. And so far, we have no problem with that oversize. Yeah.
Yeah. So that's something I don't know. What's the panel? We we did a few cases like this, but your case is beautifully done. Just something that we may need to be careful a little bit about the surgical graft that can be dilated over time, and the overlapping at least, I think at least 5 centimeters. I would say the more the better, and then in the future there might be some. Hopefully it won't happen though, but something that we may need to look for. Thank you for your case.
Maybe some role of endo anchors there too.
I don't know. Surgical graft. Yeah.
I think
at
for
least in the native aorta, just before the surgery.
I think for the case maybe it won't be problem because it stand too very long into the graft. So I think there has a very long overlapping segment. So maybe the risk of future endoleak might be minimal. But I have one question that can you tell or even predict that the lung condition before your operation? And by the way, after you do the case, can you have you review your CT pre-operatively? Maybe this can be done totally endovascular.
Oh yes. Unfortunately, I didn't bring the lung window CT scan, but the lung window CT scan of the apical part of her left lung is quite good. However, the distal, the lower lobe of her lung is really emphysematous lung. So this is quite accidentally encountered to the severe adhesion. Thank you.
So I think it's time. So we will finish this section. Thank you every panelist and all the speakers and also co-moderator.